my pleasure again to introduce Dr. Angela Dispenzieri. We'll talk about MRD testing, current status and future in patients with multiple myeloma.
Okay, thank you again. Okay, so this one has much more data to go with it. So MRD testing, current state and future perspectives. Okay, so we're going to basically talk about how it's prognostic and actually even deemed adequate as a surrogate endpoint for accelerated approval by regulatory agencies, the FDA, understanding some of the nuances in MRD testing, and then knowing how and if it affects how we manage our patients on a day-to-day basis. So I'm sure you've seen tons of slides that look like this, but this is part of the data that really got, in the US, the FDA buy-in to MRD as a surrogate endpoint. And basically, red curve is MRD negative, blue curve not, and whether transplant ineligible, transplant eligible, or relapse refractory, a major difference in outcomes if patients are MRD negative. And that was PFS, this is now overall survival, and so this is one of the reasons that it's an important marker. But there are a lot of there's nuance here. So the International Myeloma Working Group consensus criteria has laid out definitions for MRD. You need to have a complete hematologic response, but at the top line, it's this concept of sustained MRD. And so we're used to looking, we see a bone marrow, it looks great, you know, wonderful MRD, but this notion of having a year apart between measures makes a huge difference, and we'll see some of those data in a little bit. And then it defines whether it's flow negative or if it's by molecular techniques. It's typically if you are 10 to the minus fifth sensitivity of that, that is adequate, but you want to have validated techniques and assays to show that you've achieved that. And then of course there's imaging by MRI and or PET scan to show, because sometimes patients can have focal disease and the bone marrow may be negative, but they have a giant plasmacytoma in their humerus or something like that, so imaging can help. So bone marrow, we typically think of the next-gen sequencing and next-gen flow. There are blood-based assays trying to see, are there ways can we detect MRD and not have to do so many bone marrows. There's mass spectrometry of the blood. There is circulating tumor cells. There's cell-free or cell tumor, circulating tumor DNA. The long and short, at this point, bone marrow still wins, so I don't have time to go into all of these different techniques. But those assays may buy us a fewer bone marrows in order to track our patients. And then imaging is of course important, but I'm really going to be focusing on bone marrow. Okay, so this is a really brilliant paper by Bruno Paiva. This is a graph that came from there, but it talks about technique and all the rest, so if you really are interested, this is a nice reference to have. But what you have on the y-axis on the right is the relative 5-year overall survival based on the period, the decade of diagnosis, and then on the y-axis on the right, you have the incidence of MRD. And so you have by decade, and back in the day when we just had alkylators, you know, we didn't get very deep responses, you know, you always had a detectable protein. I mean, it was just a different era. When you finally got into high-dose chemotherapy, then the concept of MRD was more born, because it was like, oh, you know, we're getting deeper responses in a small fraction of patients. But the sensitivity of those MRD tests were, you know, really like 10 to the minus fourth. It was like a little better than, you know, you look under the microscope, but get a sense by flow what's going on. And then as PIs and IMIDs came along, more flow cytometry-based things, deeper look, and then finally now they're next-gen flow and next-gen sequencing that can get us to 10 to the minus 6 for flow, really good flow, and 10 to the minus 7th with next-gen sequencing. Okay, so I can't emphasize enough that not all MRD testing is the same. I see reports, patients being referred in, and it's MRD negative, and it's like ancient technology. It's 10 to the minus 4th, and that is not the same as 10 to the minus 6th. And so, and make sure you understand what the lab is doing, whether there's good quality control, and that PIVA paper goes into some of that detail of what counts. The other, just reminder, is that the half-life of an immunoglobulin, an IgG protein, is 3 weeks, and so you can often have a negative bone marrow before the blood is negative because it takes time to clear. And then, of course, in the setting of all these therapeutic antibodies, they can be seen on immunofixation. You have your daratumumab, your isatuximab, even some of the bispecifics. If you have a good immunofix, you can see that as well. So that can confound things. Okay, so what do we expect with the wonderful treatments that we have, including bispecific CARs, the rest? What are the MRD rates that we expect today? So this is a slide that I sort of borrowed from a colleague, but essentially looking at patients who are transplant eligible on the top, MRD negative 10 to the minus 6th, using a quad that includes anti-CD38 antibody, a proteasome inhibitor, lenalidomide and dexamethasone. Induction, with induction alone, you get 20 to 27% of patients are going to be MRD negative. You add a transplant in there and you're getting 34 to 45%. And then if you put them on maintenance with lenalidomide and like daratumumab as per the Perseus trial, you end up with about 65% of patients that are MRD negative. If you look at sustained MRD negativity, though, it's 47%. That notion that people can quickly, you get a negative marrow, but then it isn't persistent, and there makes a big difference there. And then among patients who are not transplant bound, again, a little bit lower rates, but you end up with an MRD negative 10 to the minus 6 of about 46%. Sustained is about 34%. And here is some data, non-eligible for transplant, just showing you some randomized trials using either doublet, triplet, quadruplets. And important to note that MRD negatives with the quads are 50, 60%. The other important thing to note is that if you look at the Maya trial, the DRD, again, the MRD rate was only about 29%, which seems a lot lower, is a lot lower than a lot of the others that are, the quadruplets. But the median PFS in that is 5 years. And if you have an 80-something-year-old person, it's not a bad idea. You don't have to go all the way. So MRD is good, but you have to put it in context in terms of safety and quality of life and all those other things. But really amazing rates of MRD negativity. This is, again, moving into early information on using bispecifics teclistamab up front as part of induction and as maintenance. So what you can see is this Majestic 5 trial. There are 3 arms. One of them is induction with teclistamab, dara, and lenalidomide. The next one is the same, but a different dose of teclistamab. And then the third is actually teclistamab with dara, bortezomib, and lenalidomide. And then patients go to transplant, and then they get maintenance with teclistamab and daratumumab. And not a lot of patients, but if you look, again, 10, 20, 19 patients, but the CR rates are incredible, right? 100%, 95%, et cetera. And the MRD rates, which is at the bottom, again, pushing to 100%, depending on whether you look at intention to treat or whatever, but extraordinary rates of response. We don't have PFS, we don't have anything, but this is yet to come. Not recommending it, we need to see trial data, and we'll see. CARTITUDE-4 is basically, again, we heard about the idea of using CAR T between lines 1 and 3. And here, again, you can see that when it's used in that setting, MRD to the -5th is basically 60-ish% if you do intention to treat, or those that were, quote, evaluable, it goes up to about 89%. Obviously much better than the dark blue standard of care, the rates of MRD. And so 10 to the -5th is the panels on the left, and 10 to the -6 panels on the right. And so, again, really deep responses, and important to help us understand, perhaps, is regimen A better than regimen B? Now, is MRD agnostic of therapy? So is all MRD negative the same? And so this is the IFM 2009 trial, and this was basically VRD plus transplant with maintenance versus just VRD and maintenance. And the two red lines are MRD. The dotted is without the transplant, and the solid is with the transplant. And there is a little bit of separation there if you look at MRD to the -6. And so, you know, the question is it exactly, does it matter how you got there? This would suggest that the progression-free survival is a little better if you got there with transplant. However, if you look at the Perseus trial, this one basically, if you look, this is Dara VRD versus VRD plus transplant plus consolidation with either Dara VRD or VRD, then with maintenance. But if you look at the upper two lines, they're superimposable, whether you were in the Dara VRD versus the VRD. And so if you are MRD negative 10 to the -5th sustained for 12 months, it's the same result. Now, if you look to the right, you'll see that way more patients who got the Dara VRD as compared to just the VRD were MRD negative. But if you got there, if you were lucky enough to get there, the gray bar, you had as equal kind of PFS, at least at 48 months, and the same thing for 24 months sustained MRD negativity. Okay, so are we ready to consolidate based on MRD status? So we don't have an answer to the question, but here's a clinical trial looking at that question. And so this is isatuximab with carfilzomib, lenalidomide, and dex, and patients then are evaluated after 6 28-day cycles for MRD. And based on whether they're 10 to the -5th below that level or they're above, they're called high risk if they didn't get into MRD negative status with the 6 cycles. So the green is the ones that got to MRD negative, and those patients are randomized to either have more ISA-KRD with lenalidomide maintenance or a transplant with 2 consolidative cycles with the lenalidomide. In contrast, the high-risk patients, all patients get a transplant, but they'll have a tandem transplant is the alternate arm, and then they're also maintained on iberdomide. And what you see is the left part of this panel is basically what happened after induction. So 10 to the -6, 73, 76% were MRD negative in the 2 good arms, the ones that got to MRD to the -5th. Obviously, by definition, the bad ones, the other group that did not have any MRD negative, that's why they're in those groups. Then when you go to the second panel, what you can see is that indeed there is an increase in MRD negativity in all patients. But the different interventions that were given, because remember the patients that did have MRD negativity at 10 to the minus fifth had two choices of therapy, either transplant or no transplant. There's no difference between that. And then again, whether you had it, if you were high risk, tandem versus a single transplant, there too was no difference. We don't have PFS data, we don't have overall survival, but this notion of changing therapy based on MRD status is something that we need to explore, but by no means is it standard. So the next question is, can you stop maintenance if low risk and sustained MRD? And so this is a study that combines data from the MASTER trial and also some patients that were treated kind of like the MASTER trial but not on the trial. And the MASTER trial design was basically the notion of giving very intensive therapy for a limited duration of therapy, but then potentially stopping therapy if there were two MRD negative in a row. Now, it wasn't a year apart, MRD negative, it would be like 4 months or whatever. But it was asking an important question, you know, can you get away with less if you end up MRD negative? And so then they also put in more patients for power to look at these 221 patients. 55% did achieve this, what they called MD Sure, which was 2 MRD negatives. And then what you can see here is they broke it down by high-risk cytogenetics. So patients who had 0 high-risk cytogenetics were, number 1, more likely to have this MRD Sure, you know, to get into an MRD negative, both 10 to the minus fifth on the left and 10 to the minus 6 on the right. And it decreased the likelihood that you would get into an MRD status as you had more high-risk cytogenetics. But the really interesting thing was, again, they stopped therapy amongst those patients who had 2 negative MRDs. The patients with 0 high-risk cytogenetics actually did very, very well. And again, I'm not saying that that means you stop it in every patient, but if a patient's having side effects on the maintenance or whatever, I think this is really important information. In contrast, those patients who have high-risk cytogenetics, you really are not eager to stop therapy in those patients because they will basically relapse. But there definitely is a subset of patients who don't have high-risk cytogenetics that have intensive therapy that could potentially get away with being off of therapy. Okay, are we ready to resume therapy based on resurgence of MRD? So these are the IMWG consensus criteria for progression. And up at the top, you see progressive disease, any of the following, you know, M spike going up to 0.5 gram, but increasing by 25%, but it has to be at least 0.5 gram, the urine protein, etc. And then there's clinical relapse, which is your CRAB features, right, calcium, anemia, etc., new lesions. That is considered progressive disease according to IMWG criteria. In contrast, relapse from CR is if you go fix positive from negative, if you go MRD negative to positive. It doesn't count as a progression, it's a relapse. And so, at this point, it's not considered a time to treat, per se. So there are individuals that do treat there, but I don't think that that would be a standard. There's no data to support that. And then if we treated every MRD patient, we'd never put a patient on a relapse trial because most of them require an M spike of 0.5 gram to go on study. But anyway, there are a couple of studies where you can glean time from going from MRD positive to overt IMWG progression. And so in the MASTER study, there was 9 months between going from MRD negative to positive, that positive state, to a true progression. In the FORTE trial, which was a KRD, KCD transplant, len, carfilzomib, it was 22 months between the first MRD resurgence and actual IMWG progression. And then in this other study, a GEM study, it was basically 39 months between. And so I think we have a lot to learn. MRD positive, certainly it's not good to go positive again, but I don't think we're ready to treat. And obviously there are differences between these studies. And these are some studies that are looking at the question, you know, where half of the patients are going to get something at MRD resurgence and the other half aren't, and data to come. So, in summary, sustained MRD is more prognostic than a single measure and may be agnostic of therapy. With a quad followed by stem cell transplant, double maintenance, or a quad and a doublet, respective sustained MRD negative rates are 65% and 34%. We have to have standardization of testing and reporting. Sustained MRD negativity can be an indication, perhaps, for limited duration therapy in patients without high-risk cytogenetics. It is not standard to consolidate for lack of MRD, nor to treat for MRD resurgence off study as of today. And with that, I thank you for your attention.